a week and a half or so ago. If you would take a minute and take a look at those, and if there are any corrections, additions, or deletions to the minutes.
Scott, I would just say technically our name has changed to Mental Health America of South Central Kansas, so you could reflect that. Thank you.
And it keeps the South Central Kansas. Okay. Any other changes to the minutes? Not hearing any. Entertain a motion to approve the minutes as circulated, with the one change of the name of the Mental Health Association to Mental Health America of South Central Kansas.
So moved.
Second.
Motion and a second. Any objection to approving the minutes? Hearing none, we'll accept the minutes with that one change as approved. Sorry, I forgot to tell you we were going to start. I started last year. So thanks for that. Again, just as a reminder to the folks that are in the room, please turn on your microphones if you want to speak, so the folks online can hear us. Thanks for joining us virtually today, or in the room today. It's great to see everyone after taking April off as a meeting together. I guess we still did some work that we wanted to share with you today with the sub panels that met on workforce and the interaction with law enforcement. We'll talk about that in a few minutes. The other topics for today are some updates on the project, and we've got a report from the county. I've got a couple of comments to make, and then we asked our design architect to be on the call as well to present kind of where we are with the design and the site plan to give you an update about that as well. Talk about the sub-panel recommendations, and then if we have time near the end, to give you a little update about some discussions around the catchment area for the new hospital, kind of what the initial thinking is around that based on the sub-panel discussion and some data that we pulled together. So with that, we'll have some other time for questions, probably in project updates, but I'll ask Tanya Cole to come up from Sedgwick County to give her update on the project.
Good afternoon. I get to be very brief, and I would like to allow most of the time for Basil, who will be able to give you an update where we're at in the design development phase of our project. What I would like to mention is just some good news. We passed our zoning change for the land piece. And so we had to go through three different measures for that. We had to present that to the district advisory board for that area. We passed that. We went through the Metropolitan Area Planning Commission, that passed. And then just this Tuesday, that went through the city of Wichita, and that all passed. And so what that means is now the zoning has changed to from general commercial to limited industrial. They made one amendment, and that was for no work release to be able to be put on that site. That wasn't anything that we had specific to our mental health hospital, but that was more for the One Rise campus. That was amended for that particular site. So the next piece on our list to do is we are receiving bids to do a geotech survey and an environmental survey on the property. So that will be done probably, I would say, in the next couple of weeks. So we'll have that done on that particular parcel for the mental health hospital. And then we have the purchase agreement that has been reviewed by the county, that's been reviewed by the state. And so right now that is with Lang Foundation, and they are reviewing that. We have that very shortly back to us, and that will be on the county commission agenda for approval, I believe, no later, I would say, than mid-June. So that's all I have for my particular updates. I will tell you, and I'll turn it over to Basil for him to go through the design development where we're at for the building, and then the site plan. As far as everything goes, as far as design, we are on schedule. So I think that's great news too. he's gonna go over his part on Zoom, but we're also obtaining copies of that. Happy to answer any questions that you might have.
Questions for Tanya? You've got one on Zoom. You could raise your hand or just unmute as well. We can see everybody. See any questions for Tanya? Sorry.
I said, we just saw it.
That's well, it was a significant milestone this week, and I just want to thank Tanya and the county team for getting that zoning change put together with the Lang folks attending each of those meetings that happened, and there was some public comment about the site and answering those questions, and I was able to come down for the city council meeting, which was a little less. There was less to do at that than there were at the other meetings, so I appreciate the county's involvement. I should have been there too to answer questions, but everybody's done a great job to get us to this point. Okay, thanks, Tanya. Basil, if you want to go ahead, we can share the design documents. If you let us know which one you want to start with, we can put it up on the screen here.
Yeah, I would probably start with the site plan. Yeah, so
Site plan, okay.
yeah. So sorry, my screen is just showing. I can just see yours through your screen, and that's the floor plan. Okay, yeah. So kind of quick updates. We're at about approximately 50% of what we call DD or design.
Basil, before you get too far, could you introduce yourself to the panel, please?
Yes, I'm sorry. Basil Sherman. I'm the architect of record, principal at Pulse Design Group, architect for the project, and I don't know if that's good enough, if I need to say anything more than that, but we're based out of Kansas City for anybody that may or may not know us. But so yeah, what you see in front of you here is our current floor plan. Like I said, we're in about 50% what we call design development. So once the floor plan's set, this is when we start going super detailed into all the small details of the rooms, casework, security, doors, and I'm happy to answer any general questions anybody has. But what you see on the plan here, the color coding reflects our security areas. So anything in green is considered like public and or staff, meaning it doesn't have to be behavioral health compliant. Really the only thing that's really public is the front door, the front of the facility. The rest of the green is really staff areas. Anything in yellow is an area that a patient would be seen, but always be observed with a staff member. Anything in red is a place where a patient can potentially be alone, or where we have the highest need for highest security / highest anti-ligature, no self-harm type spaces. So we went through that, and obviously thanks to all the state employees and Scott for being sitting in some very long 8-hour meetings over the last month or so to help us kind of get all this hammered out. But making really good progress on the project. So again, you can kind of see on the plans here our 4 wings, if you will, that comprise the 104 beds. Each individual wing has a courtyard, an interior courtyard that's walled in by the building that will allow for outdoor activities for the patients. And then every wing, we kind of affectionately at this point are calling them hands. So if you think of the palm of the hand, you'll see kind of a blue nodule there. That's the kind of the nurse station and staff work zone for those wings. So they'll be able to view straight from their nurse station straight down into each of the fingers where all the patient rooms are, so they can keep constant eyes on the entire unit. You can kind of see the taper there of the walls so that they can also keep eyes on the doors to the unit. The goal being basically 360-degree view while they're safe within their kind of perimeter. I don't recall if this had been added before your last meeting, but we now have a full, well, not full, but a comprehensive medical suite inside the space for doing medical assessments, particularly for the forensics patients, but it'll be available for the acute as well. So eyes, physical therapy, medical exams, lab draws, anything like that. That's kind of in the middle of the plan behind the front lobby. Oh, go ahead.
Yeah, sorry, I can't see the big picture of it. Can you share that? I only see it in one corner, or I only see the speaker, unless everybody else can see it on their screen. I don't have, I see the diagram, but it's not big enough for me to really see it.
Let me see if let me open it up. Let me see
You
if I
can
can,
share screen.
if I can get it shared. Hold on just one second here. Let me see. Um, oh, I see somebody's desktop. Well, let me see if I can get.
Double click it.
I can try screen sharing if it will allow me to, if that's helpful. Oh, no, it says I cannot share while another person's sharing.
No problem. You can go ahead. Thank you.
I'm sorry.
It's all right.
Where's? Yes. We can email the PDFs out. I'll work on that here. Well, Basil, if you want to keep going, I'll try to get it emailed out to the panel members as well.
Sure. So, but yeah, so like I said, we have yeah, it just came full on my screen. I don't know if it is for everybody else's, and it may just be clicking on the small image, but anyway, so, yeah, I was talking about the medical clinic. We have separate intakes, separate, admissions for both the acute and the forensic side. You can see in the bottom left-hand side of the diagram, for those of you who can see it, where our delivery dock is for the space. A big key aspect of so like I said, we added that medical area. We've also now got defined sally ports at the end of every unit. So we make sure that there's 2 doors somebody has to go through when they're exiting, just from a security standpoint in that aspect. And then if whoever's sharing, if you want to go to the second page of that document, it shows the upstairs area. So we do have a partial second story over this building now. Well, not now, but it's been that way for a bit. But it's basically all of the office and administrative areas, pharmacy, the actual main materials management storage, and a lot of the MEP infrastructures up there as well. So those things don't have any inherent no patient should get up there. So they're all shown green, meaning there's no anti-ligature, be less cost to build. So that is all staff support space that's shown up on that spot between officing, conferencing, training, like I said, the central pharmacy, equipment storage, things like that. And that's really generally the floor plan. If anybody has any questions on that, otherwise we can hop over to the site plan.
Basil,
Hey,
maybe
Basil,
before
Yeah.
you go. Oh, go ahead, Claudio.
just a quick question. Are is the configuration fixed and finite? In other words,
Mhm.
I mean, if census levels on one side were dramatically low, and could it be used for the other purpose if the demand was there, and vice versa? Is it an agile design, or this is definitely forensic and this is more the medical, and it will stay that number of beds?
So we are designing both sides as close to universal as we can. There are some unique things on the forensic side, particularly that we have to do from a security standpoint. But there's also there's nothing that would stop you from seeing a medical patient on the forensic side or a forensic patient on the other side beyond some certification and legal issues, Scott, you might be able to better address those in terms of the actual reimbursement and or operation of the facility from a CMS standpoint. But we're designing it so that flexibly, like let's say in the future, a whole new forensics hospital is built and you wanted to make this all acute. There would be some minor modifications that are needed to be done to the plan, but otherwise it's probably a little difficult to see at this scale, but all the rooms are handed the same way, set up the same way, same bathroom, same toilets. So yeah, it's nurse stations, support areas. It's all set up to be able to cross-populate both ways.
So I don't want to interrupt Basil's presentation, but to that question, Claudio, so the way we're approaching right now is you can see there's a dashed line through the middle of the building that indicates the separation between the forensic and the acute involuntary commitment beds. When we go to license and then certify this building, the forensic component will have to be separated from what we want to certify for CMS and Medicaid purposes. So we could change that in the future. We could draw the line differently or, quarter the building and we could do that. But I think at the point we are now, we're thinking of it as 50-50 with the even split of the beds between the two purposes. But like Basil said, I think we've got enough. We're building at a level that we could potentially certify the whole building and not do forensic work at all, or we may not be able to go fully forensic in the current design. But I think it's pretty. It's, I don't know, the universal is the right word, but something a little bit under universal in terms of how the building is going to be laid out and designed.
Makes sense. Thank you.
The other purpose for that is, and what we found on the other campuses is that if you have nursing staff that move between the programs, if the buildings are remarkably different, or that changes the procedures a little bit, and so that's hard to transition back and forth. That doesn't happen a lot, but in this building, every unit will have the same kind of layout, so we shouldn't have at least problems created because the one unit looks a little different than the next one if somebody moved from one working in one unit to working in the other.
Yeah, and to that end, and I kind of said that, but just to make sure everybody kind of understands what that means, every room is same-handed, meaning that every room, like it's not like you walk into one of the beds on the left and you walk into another of the beds on the right. Every room is set up so the patient bed is in the same position, the toilet's in the same position, the staff viewing window into the room is in the same position. So we worked really hard for both levels of acuity with both staffs. We walked both the OSH facility, existing OSH facility, and existing LHS facility, and trying to bring those kind of best practices of what to do and best practices of what not to do back to both for both from both facilities. So, but that was one thing we felt was very important, was that any staff member, regardless of which unit you're walking onto, the same things would be in the same locations. There's a couple of unique rooms on the forensic side that might get repurposed if you were to flex it, like the library they have for research that those individuals have to have. But otherwise, it's as close to universal as he said, or maximally flexible as we can get it, and still be able to open with the intended purpose today. But yeah, any other questions on the floor plan before we hop over to the site plan?
I don't see any. Go ahead.
Sorry, I guess I did mention, they're probably pretty obvious, that right in the middle of the floor plan are the two gymnasiums for physical activity. And on the ones on the left-hand side, we're actually going to have a walking track that you can kind of see it on this plan. It's only accessible from the upstairs. So there'll be a way for staff to get physical activity during inclement weather, but it'll be physically separated from the patients downstairs. So we felt this was a great staff amenity. We had to build that volume anyway for a gymnasium. So being able to kind of dual function that space, so there's a staff amenity for the staff members that'll work here. So that you can kind of see that track just north of the green area there in that somewhat rounded rectilinear shape there. So, but yeah, if you want to swap over to the site plan real fast. So this is, you kind of see the building, how it's sited. So the front of the building is completely parallel to MacArthur. So the way we have this set up today, or with the intent, is that there will be one drive that any public visitors and or staff would primarily enter, and then they have that one central parking lot on the front of the building. So the whole building is set up, and I'll try to walk this from left to right so that everybody can kind of follow me. The far left hand.
Maybe, Basil, there was a question here in the room from Representative Hobson.
Yeah, go ahead.
Thank you. Thank you. I just wanted to go back to your previous slide when you talked about the room for the where people can go for inclement weather.
Huh?
How many people can it contain by chance? What's the capacity?
Are you talking about inclement weather as in a storm shelter, or I'm in inclement weather? Just what I was talking about was just being able to when it was cold outside, get physical activity if they can't go outside. But the gymnasiums will be the hardened areas that are also for truly like storm shelter. And those areas would, I mean, it would be several hundred. It'll hold more than the capacity of the hospital.
Would it be the same thing for, what do you call it for, if there's is also a tornado shelter too, or just only for inclement weather, just tornado?
So the decision was made to make it hardened for in case of a tornado, but it's not a full like FEMA reinforced. Like there's a lot of things that go into making a true FEMA tornado shelter that require a lot of substantial additional dollars. So we haven't made it structurally separated from the rest of the building and separately ventilated and all those types of things. But it is hardened like what you might think of as a traditional storm shelter, yes.
Thank you.
So operationally, that will be the place of rescue, of shelter if there was a severe storm for patients, staff. And because there's the separation, we can't mix the forensic patients with patients that are there on voluntary stays. That's why there's two gyms, and they're both going to be hardened as the storm shelter for either side. They're big enough to accommodate the 104 patients and the staff complement that would be there during a shift. If it happened at a shift change, it might get really tight. But in terms of in the middle of a shift, we looked at it in terms of adequate size for that count.
And to clarify, those walls are going to be framed out of CMU/concrete, so they will be hardened, truly hardened spaces. They're just, like I said, they're just not quite to the quote unquote FEMA structurally separated standpoint. So, but yes, that's an intended place for tornado refuge. So yeah, back to the side. If we want to start on the bottom left-hand side of the site, you'll see kind of a drive lane there. So for one thing, just from us fighting a fire response standpoint, we have a loop drive that loops the entire site. You can kind of see that until it exits on the top right-hand corner. In addition to the actual main road to the One Rise campus. So that, like I said, that's both a fire access road, but also just a site navigation road. You can kind of just vaguely see the perimeter fence on the inside of that. So all the patients will be, and the secure fencing is surrounding the hospital proper, but not the entire site, if that makes sense. And then there is a screen wall, berm, and an actual physical wall on the left-hand side to the patients that are, sorry, to the properties to the left. The left-hand side drive will also be how deliveries will arrive. You can kind of see that white area that's kind of insinuated as the concrete loading and unloading zone coming in and out of the dock. And then coming just to the right-hand side of that dock area is the first sally port for patient delivery or slash drop-off. So that is the forensic side. So somebody driving a vehicle will come in, pull into that sally port. There'll be physical doors that would close behind them. Then they would unload the patient and bring them in through the intake process. And we have a similar drive on the other side. So if it was an acute admission, it would come in the One Rise drive, turn in on the right-hand side, so you can kind of follow where that's going. And there's an additional sally port that will be on the right-hand side of what is the main entrance. Again, the doors would open, you would drive in, doors would close, and then you would unload the patient into the facility. And then you can kind of see the kind of the front plaza kind of area that we have in that kind of reddish concrete color. So that is the front door of the building would be right there. So again, all the visitors and staff will park on the front and come through that main front entrance. So effectively what we're doing is creating a sort of an upside down sea of perimeter that patients will be housed within. And the open part of that sea is the public entrance of the facility, which is physically separated from all patient access, if that makes sense. And from that overhead, you can see the 4 courtyards, the kind of voids in the building, and then the kind of the protrusions of the fingers as they kind of work around. Any other features you think I've neglected to mention, Scott, or think it'd be worth mentioning that we've talked about?
Well, maybe so with the zoning change, one of the requirements that are on the site is we need to construct a 6 to 8 foot masonry wall along the western boundary of the property. So
Yep.
in this drawing on the left-hand side where that row of trees are, to the left of that, there'll be a masonry wall that'll separate this property from the neighbors. That's a condition of the zoning.
Yeah, it's probably a little bit difficult to see. It kind of appears like a bold black line on the left-hand side, but yeah, that if you see a thicker line, that's what that represents over there on this plan.
And then I was just going to call out the fence too, but you already did that. So we've made a decision to, the building will be secure. The fence is where the fence needs to be, but there's still access around the building. That is a little bit controlled, but not where there aren't sally ports or a gate that staff or visitors would have to go through to access the building. They can drive up to the parking lot unrestricted and walk into the building, staff or visitors. Those are the two.
There's no place on the building where a patient, should they be trying to get out, would go through fewer than 2 doors to do so, both of which would be secured and alarmed separately. So, and in most cases, it's more than 2 doors, but and even if they manage to get through those 2 doors, they would ultimately be encumbered by the security fencing around the site.
And then you called out the courtyards as well, which are a little easier to visualize on here without the coloring. But just again, since we're separating, we wanted a courtyard for every unit. We've got 2 forensic units and 2 involuntary commitment units. That larger one in the kind of in the center or the back third of the building, that one will be separated by a wall. So it's 1 space, but it's not 1 space, it's 2 spaces. And it's not a fence, that'll be a hard wall of some sort between those 2. So because one of those courtyards is a forensic courtyard, the other one's for care and treatment patients.
Exactly.
Are there other questions? Or so Basil, are we within, when we meet again in this is May, so in June or July, we'd be pretty close to having an exterior rendering of the building. What it would look like. I mean, this is what it looks like on the site, but what it'll look like in terms of the approach, and is that close?
Yeah, so our goal is to within the month have the exterior views ready. I mean, we've obviously been looking at some massing and kind of stacking stuff with you guys in some of the meetings, but that to a rendered scale. Actually, our goal within the month is to have that both interior, like views of like the patient units, the lobby, and the exterior rendered and ready to be reviewed. Yep, that's our goal.
Yeah. Carpenter.
Yeah, Representative Carpenter here, Basil. So on these sally ports, there are pull in and back out sally ports in, is that?
Correct. Yeah, if you look really close, you can see the turnaround zone just kind of off to on the right hand one to the right hand side and on the left hand one to the left hand side. But yeah, you pull straight in. The doors, once the doors were open, you would back out into that back out zone and then be able to drive out the length of the drive. There's a turnaround just outside the sally port.
So what size are they actually? It's hard to tell what the scale is.
Yeah, probably the easiest way to reference it, if you're you can just see a dashed line on the plans in those sally port areas. That's kind of and if you look right behind that, you can see 2 kind of diagonal lines that represent the gates. Whoever's got that, if we zoom in, if you're able to zoom in, that may be a little more visual. But if you look at it compared to a parking spot, it's quite a bit bigger than a typical transport van. It's been designed to hold a transport van with, I want to say it's 10 foot of walking space around it, but I don't have that exact dimension in front of me. But a good amount of walking space once they're pulled in.
All right, super. Thank you.
Yep.
The other, it's a little easier to see on the printout, but so on the other side of the building where the loading docks are to bring in supplies into that warehouse area, there's a tracing or a highlight of what a semi truck would look, that footprint of a semi truck. So that gives you a little bit of a sense of how big that space is, and that might help with. We can put the scale on it too, but
yeah, for sure.
It's not wide enough that you could turn around inside the sally port, but it's it's definitely a double vehicle if we had two vehicles in there at the same time.
Absolutely, yeah, for sure. And just to the right of where you see those semis, if anybody's looking at the printout or if they've opened the attachment that was sent and looking at it, that's actually a sunken utility yard there where the generator and whatnot will be at, so that the generator isn't visible from the street or from the visitors coming in and out. The transformers will be down there as well. The fuel tanks for the generator will be down there. So that's an area we're actually recessing under the ground in order to make sure that, you know, adjacent property owners don't get bothered by that, but also it's not visible from the front. And then the little bit of trees you see around that yard that I'm alluding to will ensure that the dock is also screened from the street / front of the building.
Other questions or comments? Basil said it. I think it's worth repeating just because I don't want anybody to ever say we didn't tell you this was a 2-story building, but this is at least the front part is going to be 2 stories to make sure the office space we have enough and it's off the patient units. So when you see the rendering and there's a 2nd story, I don't want you to be surprised. You can certainly be surprised when you see it. But I think you'll have noticed that we're designing it with the 2nd story in mind.
Yeah, and that was actually a very conscious decision, both like Scott said, in order to make sure that we're maximizing the amount of office and office space they need for both units, but also that we are truly separating individuals that are just billers, coders, you know, people just coming in to do work from the active patient care zones. They can come in, take their own elevator up, and never really need to get into the active hospital and secure zone. So it really helps get a very clean delineation of, you know, the different, you know, sort of public, private, semi-private and private zones of the, or, you know, or public and secure zones of the facility.
So Representative Carpenter here again, so that will have an elevator then?
Yes, sir. So there's 3 elevators in the building. The one that's the general like transport I just alluded to for staff. And then over by the dock area, there's actually 2 large gurney elevators that, or well, they're gurney size, but probably think of about more of as material transport to get, because the thought is also that all of the supplies, the main central supply materials management, everything is upstairs. So supplies come in, they will actually be brought up. And then, so that'll be another way to get to the upstairs as well. And then those actually have redundancy so that if one ever fails, there's a second one to make sure that you're still able to get supplies up and down the facility, the building.
So was that in the original estimate, the elevators?
It was in the last version that was shared. I don't know what the last, like how far back you want to say to the original, but it was in the last version that was shared by by Scott.
I think in the first schematic design we showed you, I don't know that we had the 2nd story envisioned then. It's more of a try to fit the 104 bed building on the site, and the site's large, and the whole zoning process to get it to the size that it is what we need. But as you can see, it's still pretty tight once you just put the patient units on there. So we need to get some things onto the second floor.
Yeah, and we also wanted to make sure the 2nd floor was designed to accommodate the staffing for all 104 patients. So
Right.
outside of getting the 104 patients downstairs, we needed to make sure that all the support staff would have a home up there as well. So that was another aspect of that. But depending on exactly when you're talking about original, meaning 12 months ago, no, it was not. But original meaning it's been in the plans for, I mean, at least 3 or 4 months, I think.
And was that part of the estimate that we received a couple months ago?
Yes.
The 2nd story was
Yes.
120 million.
Yes, sir.
Yes.
Yeah, there's been a few building minor square footage increases just to kind of make sure we have some secure areas that are maximally secured. But relative to total program within the last 2 months, the program's pretty well what it's been. And relative to that budget, the medical area, the added offices upstairs to make sure we can accommodate the 104 bed staffing. But that was all within that, what that estimate was created.
Questions about the design or the site? See any? Thanks. Thanks, Basil. As he mentioned, how many days we're spending, but kind of 6 or 7 hours at a time, room by room. It's a interesting process to go through and think about that from concept to actually making it work. And we've had really great participation from the other hospitals and learned a lot. That certainly applies. So thanks for presenting that, Basil. We'll have you back as we keep making progress going forward.
Absolutely. And as always, if you have any questions, feel free to reach out to Scott and he'll make sure we loop in, or I'm happy to jump on, whenever we need. But I appreciate everybody's support, and certainly the all of the state employees that have helped make this, and county that have helped make this what it is today.
I just had a couple of items that I wanted to update the panel about. As we kind of alluded to, as we were looking at the cost estimate that we have for the building, and to go to the full 104 beds, as we looked at the budget that has been approved, that we've been working from, we didn't have all of the money that we needed to build the full design. We talked to the governor's office about that, worked with the legislature, and so in the final appropriations bill, there's $26.5 million added to the project, that gets us the estimate of the design that you've seen. Would fully fund that with all the other, with the ARPA money that we've got and the other money that's available in the KDAD's budget, to build that. So we're funded to keep moving through the project. And I guess the main touch points are, we're building 104 beds, and we're building them at MacArthur and Meridian. So that's kind of the critical pieces that get us moving forward. So appreciate the legislative advocacy. Representative Helgerson was part of that, Representative Carpenter, others as well. So we appreciate that support. The other item, two other items that I wanted to update you on. So one of our recommendations as a panel in the preliminary report in the fall was requesting that the executive order, the deadline be extended for our final report, which was I think it was in May or June, to extend that a little bit longer, so we would have time to work on additional recommendations that are in our charge. Just today's Friday. Yesterday, I got the approved executive order that makes that change. So our final report to the governor and for the legislature is due on September 30th, 2024. So that's still not too far away. It's a lot better than like next week. So we've got a little bit more time to keep working on the recommendations and thinking through some of the other topics that we've identified. But so that's got that accomplished this week as well. And then the final update I wanted to provide, we'll talk some more about workforce in just a minute. But also in the final budget approval, there was some additional funding added to the KDAD's budget for an effort called the Center of Excellence, which is a multi agency effort involving the community mental health centers, Wichita State, University of Kansas School of Medicine, Wichita, community and technical colleges, just a lot of people working on that effort to try to build capacity for workforce development, educational pipeline, pathways for behavioral health professionals as well. Joan, if you want to add things to that, or Mary, feel free. But so that funding's been added to the KDAD's budget to fund some of their initial ideas around nursing scholarships, and I'm not going to get it wrong now if I just guess. But so anyway, so we're and KDAD's is part of that. I'm representing the agency on that group, and was participating in the call. I think they meet weekly or every other week while I was driving down today. But so I think that fits very neatly with the recommendations that we've already made as a panel about workforce. And then we'll hear about from the sub panel as well. But I did want to let you know there was some funding in the budget starting in July to move some of those efforts forward.
Can I just add that I think for our first year of the Center for Excellence, only been in play for about 6 months. The legislative win was really significant because it's to the tune of $5.4 million. A lot of it going into enhancing psychiatric spots to produce more psychiatrists and some other academic programs. But it's year one. It's really exciting for our region.
And highlights a lot of the partnerships that are already in place that are, the things that we need to build on, and particularly here in Wichita and around Wichita State, but other educational partners as well. Those were my updates. Any other questions about project updates or where we are in the process before we move to have Monica walk us through the sub-panel recommendations? Oh, sorry.
Are we still, the panel still taking recommendations, right? So how does it work? Is it basically every meeting we can recommend something, or what's?
Sure.
Is it? Okay.
Yeah. I think the last, when we worked on the preliminary report, we had a couple of focused discussions about areas that we wanted to comment on or make recommendations. And we drafted some as staff as places to start, so we can work on that. So in terms of the areas that the panel's charged to work on, workforce, the interaction with law enforcement, other community services, private is how the hospital operates, whether they're all state employees or privatized. We started that discussion, but we haven't, I don't know that we're at a point of a recommendation yet. Seems like there's a fourth question, but there's some particular things that we were asked to make recommendations about. And we can build some time into future agendas just to have that as part of the discussion that we have here. Other comments or parts of the project updates? Okay, we'll transition to the sub-panel recommendations. We can put them up on this. Well, I don't know that I sent the files to Nicole. I think I sent around the recommendations to everybody in advance by email, so you should have them if you're not in the room. If you need them, raise your hand or drop something in the chat and I'll email them out. But our Greenbush partners helped us through this process, assembling many of you, but also other people to work on these particular areas. So Monica, if you want to walk us through the recommendation.
Hello, everybody. Monica Murnian from Greenbush. And a big thanks to all the folks who helped us in this work groups in the month of April. Just as a little bit of background, we tried to include members of the public who had shown interest, different folks who had presented to us, and we had a nice mix of people that volunteered their time to come in and have some conversations. So we had 2 work groups. One was around workforce. The second was around law enforcement. And each of those work groups met 2 times via Zoom for an hour and a half each time. As you can imagine, wrestling something like this to the ground is pretty difficult. And so we tried to go at it in a way that allowed for everybody that was volunteering their time to have a voice. And then also to provide significant background information to the panel members so that when they came to the meeting, they knew of work that had previously been done. They knew of different parts of conversations, and they also knew about this panel as a whole. So following those 2 get-togethers, we did send out a draft set of recommendations to each of the panel, sub-panel group members. And that's what we bring for you today. I don't think anybody on the panel would say we covered everything and we did it perfectly and, all bases are covered here, but I feel like it was really great input in the process from a lot of different people with a lot of different perspectives. So workforce, as you can imagine, was the most difficult to really try to get something measurable right? It's very easy to say, we want more, we want them to be the best, and we'd like to have them when we need them. And yes, we like unicorns too. So we really tried to use data to drive those decisions of the recommendations and also make them in actionable items. And so as you can see, they're lumped together. The first one is very specific to psychiatric residency. And we were very lucky to have Dr. Lincoln stay in with us through that whole process. And the recommendation is very specific. It's specific for 2, and that it's for the 4 full years. So one of the things we tried to do was think about short-term and long-term impacts on these. So that's the first one. The second one was our way of trying to organize multiple layers of staffing credentialing that will be needed. So as we heard when we had presentations earlier this year, we have a nursing perspective, we have a perspective of psychiatrists, we have a perspective of clinicians. And so we tried to make sure that we touched as many of those as we could with multiple methods. So where appropriate, we made KDADS the actor in all of these to move forward on. And so you can see there's a system of student loan forgiveness in A. And we really tried to hone it in, knowing that the workforce issue is true and real for every type of behavioral health provider in Kansas. We really tried to focus in on the hospital and how we can ensure that we get the workforce that is needed for the staffing that was recommended. Also in B, that had to do with the scholarship piece. So knowing that scholarships can be a smaller amount if we were looking at a CNA or a nurse, but then quite larger when we're looking at a psychiatrist or clinician. So we really tried to make this so that it, again, was tiered, and we included a listing of folks in there. There was a lot of conversation about that. You know, how long do you make the commas? You know, how many commas do you put into this? But we felt like we got pretty close. Also in C, this idea of the pipeline from high schools, and knowing that the Kansas State Department of Education, it has been working on updating their career and technical education pieces, and also blending in lessons learned from what you've done here in Wichita regarding the aeronautics type of pipelines that you have built. We had conversations, Scott had a conversation and aligned with what KSDE is doing, and hoping that that will help that very early pipeline. Indeed, this was specific to the career and technical education piece that we heard earlier this year. You may recall from WSU Tech, we can't find teachers, we can't hire teachers to teach these classes, and there's just some infrastructure issues. So we felt like we addressed that. And then moving on into, you might remember Juliana from the nursing board in E, very specific recommendation about licensed mental health technicians. And we wanted to build that into this piece also. And then finally, in that area of specifics for varying tiers, the financial support for clinical placements. So that was also heard by this panel as a barrier to both students being in a clinical placement and also for clinical sites. So that's why we popped that in there. On 3, switched over to we really talked to it was hard to get down to the recruitment and retention piece. You know, how do you recruit? What is the magic thing that makes people come to work for you? And so what we were really trying in the panel we finally got down to is this idea that making sure that if there is a pocket of people out there who have a desire to do this type of work, are we creating a pathway for them to do that? Maybe you could call them unlikely suspects. And so we this is not super specific. There is no like specific action movement towards this, but it is, I would call it a placeholder to say we need to recognize that there may be multiple other ways. So for example, Senator Reddy brought up military families. And, you know, is there a really specific conversation that can be had about that topic in general? So that's the number 3. Number 4, this got very technical very quickly, as most conversations, you know, around this very complex subject do. There have been great strides in the state of Kansas regarding reimbursement for tele-based services over the years. Dr. Lincoln pointed out that there are possibly some holes in that as it relates to inpatient psychiatric care. And so because the panel were not technical experts on this, but there was a piece in there, we did put in a recommendation to just have that review done in some way during the next legislative session to see if there is indeed a way that we could strengthen telesupport to the hospital to ensure appropriate care. And finally, on number 5, a memorandum of understanding with the biomedical campus. So it was very clear that the good work that is being done here in Wichita, we need to all be working together and building off of that. There was no specific area that came out of this, but that idea that we're always working together when it comes to research and training and just being interconnected as we're being collaborative and creative. So that placement, that MOU would be future facing, but yet the workforce group really wanted to make sure we made that connection. So again, not totally, you know, didn't fix everything by any means, but a good place to start. I'd be happy to provide any additional interpretation of those recommendations or give it my best shot.
I have one question. On 2A, where it talks about student loan forgiveness, I know we've had issues because the VA, they take the clinicians there into account with our overall count, which makes it harder to get student loan forgiveness. Is that addressed in this? I just don't know how that fits into this.
Right. It was, those discussions were had, you know, all the nuts and bolts of student loan forgiveness are quite complicated, depending on who the forgiver is. Right. And so what we had hoped with that one is that there would be a system in place and KDADS could be the leader of that conversation to say, here is the clear pathway for this type of provider or this type of person or this type of loan. And so there's nothing, the thought would be that KDADS would create some kind of map and if appropriate, then say, we'd like to go to the legislature and fund blank number dollars through this special program. But of course, that would all come out in details later on. The point being just making it easier.
Okay, that's really helpful. Thank you so much.
You're welcome.
And loan forgiveness may have been too broad of a term because, I mean, even KDADS doesn't write the loans, so we can't forgive them.
Right.
But I think the mechanism was somebody who's working in a job or somebody you're recruiting, they've got $100,000 in student loans, and we could do it as a grant program and say, boy, we're going to give you $50,000 to apply towards your loan. Not part of your pay package, or maybe it is.
Right.
But so it's probably not really forgiveness. It's more of a funding of underwriting people's loan.
Mm-hmm.
Given the act. Yeah, Senator, Representative Carpenter and then Senator Reddy will come right up.
So, was there any talk about on these programs, loan forgiveness and stuff like that, having a minimum working time in Kansas?
So there was conversation about all what I would call caveats to any of these programs. Where are you working? How long are you working? Those kind of things. Yes, those all were brought up as important aspects to ensure that we meet the intent. Right. And so, yes, the details would be worked out at a later point. But yes, the group did talk about that and felt that that was important.
Yeah, it's always a concern of mine. We train all these folks and then they leave our state.
Sure.
Senator, ready?
Yes, thank you. Yeah, no, it was a very good discussion. I really appreciate how organized it was and collecting all the thoughts and the experts at the table. I think when we talk about loan forgiveness, one of those was that they have a certain number of years where they're working in Kansas. The other challenge we have when we look at workforce issues is that all of the mental health facilities are looking for workforce. So even if we have this as our target for the psychiatric hospital in Wichita, that we don't have a means to say you need to work at this specific spot to get a loan forgiveness, because if we're talking all of Kansas and all of the challenges we are seeing, it will be a bigger challenge, but we are going to be meeting certain needs and maybe even increasing preventive measures in those communities so they don't end up at a psychiatric hospital. The other thing to this is when we look at compacts, we have nursing compacts for militaries, waiving licensing fees and such. So I think there's a broad spectrum that we can look at to increase the workforce. And ultimately, it'll come down to salary and sustainability and making sure that their mental health is also being taken care of. I appreciate all of the work that's been put into this. And certainly Monica's done a terrific job, and we will continue to work on it. And I was glad to be part of the subcommittee. Thank you.
Other comments about any of the recommendations? I don't think we're at a point that we need to adopt these or add them to our report, but we'll kind of keep them as a working list. And a few of these, the Center of Excellence funding checks a few of these items as well, but we ought to map that. We did a really good job, and I appreciate the Greenbush's team in pulling together recommendations from the mental health task force and other legislative committees that have met. We did a lot of the homework that gets us to this point. We got this done before the omnibus session was finished, so we couldn't go back and map to things that were actually included in the budget, but we'll take that step as well.
So and that is another thing that I want to point out to the larger panel. We will go ahead and share with you all the background information that we shared with these subpanels. So if you are out on the patio this summer and want to peruse that, for 5 or 6 hours, you can sure do that. We had staff that made it super easy to read about every report that was ever written. Melinda really helped pull it all together so that they could come in and know what other people had talked about and other people recommended. So the law enforcement group was a bit of a different group. Thanks to Sheriff Easter and Mark for being super helpful on that group. We were also joined by the Wichita Chief of Police, and we had some other folks from surrounding areas that joined. So it was a great conversation. As you would imagine, the recommendations are a little more specific. They had really, I think one of the best things out of that group was some of the folks had not been engaged in the process or the understanding of what the hospital was, what the intent was. And I feel like we made great strides in getting a level of understanding out there that was better than what we had before. So with that being said, the number one recommendation, again, these are not ranked in any order of priority, that the legislature defined the catchment area for the South Central Psychiatric Hospital region under the Care and Treatment Act, which may include, please note the word may, Sedgwick, Reno, Harvey, Butler, Sumner, Cowley, and Kingman. There was quite a bit of conversation, and there is some background information that we took into account on the catchment area. We had people do crunching numbers behind the scenes. What we did was look at the admissions and tried to make the best guess. Also discussed current partnerships Like, is this county already working with this county because they're in the same judicial district? You know, those kinds of things. And so this is the listing of what they came up with, but knowing that it would probably have to be fluid up until the last minute. The second one is very specific and was very well thought out by Mark and also very much agreed upon by everybody on the group. And so I'll go ahead and read that since we've got some people online who may not have it. The advisory panel recommends the governor or legislature request the Criminal Justice Coordinating Council or the Judicial Council initiate a thorough review of the Care and Treatment Act for mentally ill persons, listing the KSA, and propose changes to the involuntary commitment statutes for the 2027 legislative session. The review should include identifying processes to prioritize individuals in crisis screened for involuntary care and treatment to ease the strain on law enforcement resources. So this is a very technical response to a very real day-to-day issue that was felt by the individuals who were on the call. And this was, I think I like it. I kind of tie this back to conversations we had in this panel early on. Are there some things that need to be tweaked in existing statute or certification processes or, you know, the technical piece of it that could ease all of this also? So that number 2 reflects that. Number 3 looks at a budget enhancement submission to increase funding for regional case management and behavioral health providers. So interesting that the law enforcement folks said, we really need help prior to. We really need somebody to turn to upon as an intervention. We need help. And we know we're not the best folks to do this. So we would like the legislature to consider the pipeline and how we can support so we don't get to the law enforcement piece. So that was very, very clear. Recommends funding to ensure the establishment and operations of the 104 beds. So check, but they wanted to be really clear. They thought that that number was appropriate. And then KDAD's established a formal intergovernmental agreement among law enforcement entities, emergency services, fire services, regional behavioral health providers, and KDADs to ensure effective communication, clear expectations for process, and mutual obligation. So that was our overarching goal about, well, who do we talk to? Who do we call? Where do we go if there's a problem? How long are we expected to wait? When, you know, all of those things that sometimes break down once things are going, they recommended that this be in place and reviewed on a regular basis. So kind of a safety net. And then finally, provide a report to the full advisory panel about agency efforts and programs for youth. Now, this was an unexpected, or not unexpected, it was a great conversation about, yes, we're really, really happy about adult services, but we need you to know the youth service options we have are not significant enough, that we are in a crisis, and they wanted you guys to know that. While it may fall, we did talk about, you know, does that fall in the purview of this group or not? It was important to them to know that they could use some help there. So they thought that might come in the source of funding opportunities or talking about gaps or just a more concerted effort. So the law enforcement group talked about all of those things and bring you forth these recommendations. And I thought they were an interesting mix of very technical and also broad.
So I look on number 2, 2027 legislative session. Is there a reason to put it that far out?
That it be reviewed. Thorough review of care and treatment. So I believe the time frame that we did, and Scott helped me here, was that in the 2025 session, the legislature would have to say judicial council or the other group, please do this. To bring back for a change in 2026 legislative session. So I'm not sure how we got that extra year, other than if maybe Mark thought it was going to take that long. Do you remember, Scott, how we got to 2027?
I wrote that one. If Mark wants to take credit for it or take responsibilities, I'll let him do that. But in my experience in working on similar kinds of reviews that the Judicial Council does, or the Coordinating Council does, they take a while to go through the whole statute unless they have a really specific question or section they're asked to look at. If you just say, take the whole Care and Treatment Act and work on it or improve it, that takes a while. So I wasn't sure in trying to write it as a recommendation. This panel can make recommendations to the governor and the legislature. I think only the legislature or the courts can order a review like this. So I didn't know when the first date would happen to then give enough time to do the review to have recommendations to the legislature. So in putting those things together, I said 2027. We could take the dates out. We could put different dates in. But I just wanted to also be realistic. These don't happen quickly in the couple of examples that I've got some experience with. But
that was my thought, was it's already at the middle of May. By the time this would get to the governor or the courts to make the recommendation, it would be the fall. There's no way they'd have a report turned around for the 2026 session. This is something that's going to take 6 months to get stood up and a year to go through. Candidly, 2028 may be more realistic, but we're talking a plenary review of the entire body of an act. This is not something that's going to be done overnight. So I think that's why we picked that date.
Thanks for that background.
if there are some things that are quick wins or things that we know don't work well, I mean, that could certainly go faster. But what the group talked about was a more comprehensive review, looking at what other states do, really thinking about a modernizing effort in the competency statute, and just thinking that was going to take some time to get it done and do it right.
Well, you know how impatient I am.
I have some experience with that as well.
And if there was anybody else that was on that committee that has any other background on any of these, please.
I did want to make one comment about the number 5, the formal intergovernmental agreement. I mean, I don't know if we've talked about it here before or not, but I mean, even in some of the stakeholder meetings we've had or town hall meetings, I mean, there have been questions from other jurisdictions in Sedgwick County or fire support. What's that going to mean for when you stand up a facility of this size with the kind of patients, what that takes? And it just seemed to make sense to the group that we lay that out in advance, so it's we don't have to let it just happen organically or make assumptions about it. We could lay it out as we're working kind of together on the project anyway. So I thought that was a good forward-looking, not that we'll get everything right, but we can at least say, well, kind of to Monica's point, if there's a fire alarm, who's going to respond? And do we know who that is? Does everybody aware what that takes for resources? If there's a patient injury and we call 911, who do we expect to respond? Just kind of laying those things out in advance before we're open and operating.
I have one question on number 6. If we are given a report to look at, can we also make a recommendation that go to the CJCC if we're having them look at this other thing, and as the county is talking about revamping what CJCC is and what that's going to be in the future, that might be something that we can add on the list of things that we would like this group to put some focus on.
Yes,
Our recommendations are from the governor.
I
but
think
if we
so,
can-
don't you, Scott?
I think that's within the it's within the scope of what we've been asked to work on. And once you open up that section of the statute or the forensic part, there are parts for juveniles and for adults. So I don't know how we would avoid it necessarily, but we did have a little talk about scope creep and it's kind of what we have authority to do and what our recommendations can be about, but this seemed at least to explore it more. Yeah, in the right vicinity of things that were important. And actually, I think it was the Wichita police chief that said, every patient that we're going to admit was at some point a kid or a youth. And so if you want to think about the impact of services across the whole region, you got to think about the pipeline of potential patients that are interacting with law enforcement or mental health or other kinds of services.
So these are for you just to sit on for now and consider. We have, considered how to continue to use these folks. All were very kind and welcoming and said, let us know what else we can do to help. And so as we progress with the panel, I think these will be a great place to pick up and start. So I will follow up with you and share with you what each subpanel received. And then I think from here on out, we just kind of wait and maybe adapt some of the dates, see if these become appropriate for the final report.
We did write them in a way that they're recommendations from this panel in our final report. So we were trying to, at least I was hoping to save a step of, we don't have to have the subpanels recommend something to us that then we have to translate. We could start from what our recommendations would be as a panel in that final report, given that we don't have unlimited amounts of time.
Would it be okay if I took 2 minutes and talked about one other area of outreach that we've done regarding?
Yes,
Yeah. So again, our task is to make sure that any place we can gather a little bit more information to bring back to you, the better. We had, after discussions with Scott and his team, we wanted to make sure that we honored and kept in communication with all the people who have signed up with us to hear more, either when they were at a town hall meeting or through social media. And so we put together this idea of every couple months doing an informational email out to folks, and then also just asking for some feedback during that time. And so that just happened on April the 26th. We have 202 email addresses that folks have provided to us saying, hey, just keep us informed. We'd like to hear from you. And we have software, if you think somebody's not watching your, email openings, they are. We can tell you that about half of those people opened the email and they like, oh yeah, there's something there. And then also we had 22 people complete a little short survey at the end of asking their feedback about some specific things about the hospital. So for example, when asked what factors contribute to providing high quality mental health care within the community, what are your top 3 things? So we just gathered a little bit here and there. We have a nice little 2-page report ready for you that we will send out to you again. And then we plan to do that again, maybe the month after next as the project continues to grow. So while we aren't hosting a town hall this month, we did do some additional reach out.
How do we get on that list if we're not already on it?
Yeah, we can make sure that all the panel members were on there. We have collected those at the different events, and that's how we did it, but we can for sure.
Yeah, I would love to be added. And then can we share a link or something to the community members who we hear from saying, here's a great way to stay up to date on what's going on?
Why don't we send you a nice little easy peasy summary email where it has all the links in it to everything. And then that way you can just forward it on.
Thank you so much.
We'll do that next week.
Just a note. So have you addressed the work release on that?
Sorry, I don't understand.
For that. Okay. If you would like, I could answer with the zoning changes that the city just passed, they made it so that cannot happen. Yeah, there's never been any plans for it, so.
There is no.
Yeah.
So this is even before you did the zoning, this is not over. So anyway, okay. It's something that you probably could knock down in your information out there.
Yeah, we can get with it with KDADS and follow up on that.
And also, I know we've talked at least internally at the county, and I think Scott as well, but can we try to figure out a time where we can do the next town hall? I know after the purchase of the land and the zoning and all these things have changed, it might be good just to do a follow-up with community members in that way. I don't know if we want to invite One Rise to that, just because I know a lot of the conversations and questions that are happening kind of revolve around what they're doing and not necessarily this project. So we can maybe differentiate some of that and then possibly bring in, I don't know if the city of Wichita would want to engage in that or not, but maybe they would, city or county and state, of course. But I think if we could say, yes, we're going to put this newsletter out or whatever that is every however often, we're also going to have another town hall. And then before the facility opens, we'll have an open house. I think that's going to help just alleviate some concerns from some community members.
Absolutely. We'll work with KDADS to get that on the books.
Thank you.
That's one of the things we talked about after the zoning was complete. The other timing element of that, once we have a rendering of the exterior of the building, what it looks like on the site and what it looks like when you approach it from different angles. We thought that would be a good time to also share that with the public, because that's kind of the next phase. And I don't think if Basil's still on, but that's in the next 30 days at the most. So we could probably look for a date. It's still May and it's Friday. Well, I was thinking in June sometime would be good. And we have talked, or at least I've talked to the One Rise team about it as well, because they have some things they would like to talk about and share. And it does seem like some of those questions are more the other purposes that are other kinds of things that might get developed on the larger site, not just our corner of it. So we'll look for another date. That's a great suggestion. Other thoughts or comments about the sub-panel reporting or work product? I don't foresee at this point a need to have additional sub-panels, but as we get into some other topics, again, we haven't, of the issues that are under our charge, privatization option is another one that we need to deal with. We haven't assigned that to a sub-panel, but I think we've probably gone as far as we need to with the sub-panels, but I think they all were available, willing to work some more if we had other particular questions to ask or other information to gather. So as you get a chance, again, you're reading other materials. If you want to look at those recommendations, think about where they could be more specific, go in different directions. I'm happy to take those comments as they come in. The last item on our agenda is a discussion about the catchment area. So this was in the law enforcement recommendation. I did want to just take a couple of minutes to share the information that we provided to the sub panel about catchment area, just to give you that context. And I sent that around. The couple of things to keep in mind. And this was one of them is a comment that Sheriff Easter had in the sub panel meeting. I think Mark Bennett mentioned it as well, but it was very clear, and I think it's consistent with everything we've talked about as a panel. But the target population, the target area for service for this facility is certainly Sedgwick County, given its location, but it needs to serve the broader region, more than just Sedgwick County. And that came across very clear, and I've not picked up that anybody has any objection with that. So what that meant to me was that means as we draw a catchment area for this facility, needs to be beyond just Sedgwick County. That seems pretty simple now I say it out loud, but it was worth note. I think it's worth calling out and being specific. Second, the catchment area will apply to the involuntary treatment side of this facility. So for forensic beds, we manage those centrally across the system, Larned, Osawatomie, and then when we had this building. So it doesn't really need a catchment area. That might be something we defined in this MOU to talk to specifically with Sedgwick County about defendants that are in the jail or in the court process. But the formal catchment area, it doesn't necessarily apply. So it applies to the other other side of the business. So that led to the conversation that we had about thanks, Representative, about what the catchment area might look like. So I think we're going to try to put on the screen the PowerPoint, and there it is. Okay, so what we did was we used the 2023 admissions data for Larned State Hospital on our civil commitment side, the state or the psychiatric services program, Osawatomie State Hospital, and our acute unit there as well. So it takes all of the admissions that happened in 2023 and mapped it back to the county of responsibility for each patient. So so that would, right now, if you're in mental health crisis and you're screened by a mental health center for state hospital admission, you are assigned to the state hospital that corresponds to the catchment areas for Osawatomie or Larned. And generally, the eastern third of the state goes to Osawatomie, including Sedgwick County, and the western 2/3 would go to Larned. So that's what we mapped out. When we looked at it, then the sub panel said, well, take Sedgwick County and all the counties that are adjacent. And that's what we looked at here. So, and I'll show you the maps here after we go through just kind of the numbers. But if you take the 2023 data of all the admissions that we have that are civil commitments, 66% of them go to Osawatomie or the Adair Acute Care, that's AAC, and the other third essentially go to Larned. Then in terms of numbers, that means there's a little over 1,100 admissions to Osawatomie and 550 or so to Larned on the civil commitment side. So if you add, or if you take out of that mix, then Sedgwick, Reno, Harvey, Butler, Cowley, Kingman, and Sumner counties, this is what it would look like. 14% of those admissions would come to the new hospital, and you can see how it's a little harder to see on the pie graph how that takes away from the other hospitals. But this is what it looked like in terms of numbers. So it'd be roughly a little under 250 admissions a year from those counties for the new hospital. And the one that really did it for me in terms of, really told the story was this one that compares what did happen to what would happen if with that catchment area drawing. So there'd be a pretty, I don't know what that percentage change is, but the drop for Larned is a little bigger than the drop for Osawatomie in terms of adding this as the catchment area. There's some discussion among this system of, the new hospital serving Sedgwick County ought to take some pressure off Osawatomie in terms of admissions and wait times. This suggests to me that we are not taking quite enough pressure off Osawatomie with the new building, but again, that's just one view of the data. Would you be able to put the maps up as well, please? I think that kind of shows. So this is the admissions for Larned by county. And the largest numbers are there in the darker red colors. And you can see, point out where Sedgwick County is, but you can see kind of, if you take those, thank you, that's great. The counties around, they're all pretty highly correlated with people that go to Larned. So one concern that I have as not being from here, but kind of looking at the map, if Butler County, for example, continues to admit primarily to Larned, every patient that comes from, or not every patient, but many patients that would go from Butler County to Larned are going to drive right past our hospital. That seems problematic to me. So we got to think some more about that. But it takes a lot of the admissions it would take all the admissions from Reno County that now go to Larned. And I think that may be where the tension point is, because that's about 65 admissions a year from Reno County that now go to Larned. If you could put up the Osawatomie map. So this is the same information, but for Osawatomie, showing Sedgwick County and Harvey. And again, where the shift would happen. You'd probably get more of it from the Larned admission data, but So this is the information that we looked at in thinking about the catchment area, that kind of drawing a circle around Sedgwick County. It is simple, makes a lot of sense. I think there may be other ways to approach it. We've got to think about capacity at this hospital as well. We don't want to create a situation where there are so many potential admissions that we run long waiting lists there. That's something to think about. And the other consideration, then I'll stop talking and see what questions you might have, is we have tried in the current catchment areas to not break up a community mental health center catchment area. So the mental health centers that serve that do the screening for our state hospitals should know where patients are going generally and where they're coming from when they come back to the community. Taking just those surrounding counties would break up a couple of the catchment areas or a couple of the CMHC community CCBHC catchment areas as well. So we may just want to think about that. This isn't informed by a discussion with the mental health centers. I talked to their board of directors and the full all of the executive directors. They meet monthly or almost every month, and I just went to their meeting. Let's say it was Wednesday. Anyway, this week, said we need to have this conversation. So we should be informed by that as well, because that's kind of natural treatment areas, natural flow of patients. But anyway, as a place to start talking about catchment area, this is the data that we shared, and the recommendation is to at least look at those surrounding counties as a place to start. Claudio, your hand's up.
Yeah, Scott, is there any merit to having sort of more of a situational plan? In other words, can the catchment area be redefined over time and either expanded in some way so that the desired effect and relief maybe to both Larned and Osawatomie are achieved while maximizing the facility here? So in other words, prepare for a different catchment area and enact it as appropriate.
I think that's a fair point. Now those are defined in statute and regulation, and that's a policy choice that happened and has changed as Topeka State Hospital was closed and other things have happened. So I think we could make this as flexible as the legislature would want to allow.
Yeah, I was just thinking some agility here as a new facility comes online,
Right.
and really it's about serving the residents of the state the best we possibly can, and being able to pivot a little more quickly is just a thought.
Right. And we have a model for that with the state institutional alternative hospitals that they don't operate catchment areas. We tend to work on first available closest, which is another way to potentially approach it. I do want to respect judicial districts that do competency work, the mental health centers, and what they're, some expectations ought to be in the system as well. But I think, again, agility makes a lot of sense, and available where there's an available bed that's close. I think that matters as well in these, really talking about people in crisis. So we need to, agility is a really good word to use and a goal to set. Other questions or other data you'd like to see going forward as we kind of refine this as a recommendation, or voices you'd want to hear from? I've been really curious what you think, Joan. I don't want to put you on the spot on a Friday afternoon, but I'm kind of curious what your thoughts are.
Yeah, I was just thinking about the whole CMHC, CCBHC, piece. And, when you start thinking about Butler County, that includes Greenwood, and Ellis County and Elk County and others. You talk about Cowley, you start talking about that being part of Fort County down in Independence with their surrounding areas. It does get really interesting when you start thinking about trying to keep it sort of contained to natural groupings. I just worry, if we get it statutorily changed, what happens on day one when that hospital isn't fully staffed?
Yes.
And then we're stuck with a backlog. That's where I think Claudio is probably coming from in his head too, knowing that the likelihood of being fully staffed on day one is probably small.
Yeah, that's a fair point.
Those are the thoughts that come to my mind on this.
Other thoughts or comments? As you reflect on this, or and you think of, it'd be really good to know this data point, or look at, we want to add the 2024 information to this as well, and maybe put some more data points on the map. I think that might tell us something else too. But if you think of something else that you've got a question about, please let us know so we can keep informing this decision. I think this question in particular, we need to have a recommendation by September for that final report, where maybe some others can be a little softer. This one, and maybe the recommendation is there shouldn't be a catchment area until you have a better idea of the flow. And that's great, but I think that's one that we need to weigh in on in a deliberate way with our time to study it. Okay, any other topics or questions that any of the panel members have for today? We'll look for, I don't know what the third Friday in June is, but we'll look for a date in June also to meet. Monica, have we talked about what the agenda items are for that meeting?
Coming back to a little bit more about privatization, I believe.
Oh, right. Okay.
Right, just kind of firming up a little bit more there.
Sorry.
First, when it's fine.
I'm sorry, I apologize.
Yeah, you waited. Didn't you?
No.
And we also had
originally in our conversations around firming up that staffing numbers, so we could continue to talk more about what the impact is going to be on workforce.
I think our staffing model, any update on the design and what we can kind of frame some more questions around the privatization question would be a good. And then other recommendation we want to explore. I think that could be our June tentative agenda. Okay. Well, if there aren't other items for us, I'll entertain a motion to adjourn for today. Representative Hobson has a motion, and Commissioner Lopez seconds. All those in favor say aye.
Aye.
Aye. Well, thank you very much for your time today and your continued participation. And if you need something, don't hesitate to ask. We'll work on another town hall as well. That I think is an important step along the way as well. But all righty, everyone, thank you very much. Have a great weekend.
Safe travel.